Thank you so much for the opportunity to speak today and share some thoughts and ideas that we put together over the last several years, both working with the Sheikh Khalifa Stroke Institute, but also with my years of practice before that. So, I feel as though this moment and this time in my career has been shaped by a lot of different experiences and people and opportunities. And again, I'm very grateful for this one to share here today. At this time, I don't have any relevant disclosures. And I want to frame the nature of our conversation as it is to be around that of the practitioner, the survivor, and the caregiver. Some of the common problems that we see, not just with stroke rehabilitation, but also with other areas of our practice, is that, we all like to talk about the team and we talk the team talk, but it's a challenge sometimes to walk the team walk. There can be a lot of different contributing factors to that, whether it's, a lack of adequate education or community resources. It can be a result of a lack of understanding of what our patient needs are, or just a misunderstanding or lack of experience that they have with the rehabilitation process that, we deal with on a day-to-day basis, but is a completely life-altering experience. A lot of the resources out, we try to look at an empowerment model where we're involving more parties, more people in the decision-making process, so that outcomes or avenues are not being dictated, but are being offered. In that way, we can instill a greater confidence in how they perceive the provider's involvement in their success. And so, while in my previous slide, you didn't see me working with a lot of stroke and neurorehabilitation patients, the reason is I'm more of a musculoskeletal guy. So in preparing for this talk, it was, particularly challenging because I'm thinking, well, what am I gonna share to a global gathering of neurorehabilitation experts? And it really is around this idea of experience as a leader of teams, and how we pull them together in order to achieve a successful outcome in both our operations and clinical success. And that leads us into, some of the other, support is also a key determinant. It's a key determinant of a team success. The cost of care can be very burdensome. The ability to pay in different models and different locations around the world can affect, the outcomes of someone's stroke care. In some settings, they don't have universal coverage, or they don't have insurance. So it's incumbent on them to pay privately. Socially, as we heard a great talk before this, the importance of social support, peer-to-peer conversations, and also professional resources, just like this conference is today, are key factors in helping to overcome and improve, the well-being within our three key constituents. So today, our objectives are to propose a model of sort of the 5 functions of a team, which is building upon one of the best-selling leadership books by Patrick Lencioni, called The 5 Dysfunctions of a Team. We'll discuss some of the prioritization, why it's important to have a dialogue as we are today. We'll relate some of the initiatives that have been implemented as a result of the Sheikh Khalifa Stroke Institute, and we'll discuss some of the strategies that ultimately may help improve our outcomes. So I'm going to frame this again in this kind of conversation around the team. And so, what do we mean by a team? We'll try to paint a better picture of what that is, provide some boundaries there, and then how do we overcome some of the common dysfunctions that occur within a team, whether it be building trust, helping to master conflict, achieving commitment, embracing accountability, and focusing on results. And then hopefully, if we have time at the end, we'll have some time for questions. So, as we heard in Dr. Keatland's talk, the burden on the practitioner and provider is very well documented. The stress and both physical, emotional, psychological stress that comes from caring for patients, especially in a high stress environment. It leads to burnout. It can cause issues with safety and affects sometimes our less than professional behaviors, which under normal circumstances may never be witnessed. These issues around resilience are really right now one of the central themes, and I think are one of the major problems that healthcare employers are grappling with, globally, ever since the Great Resignation. This focus and awareness on resilience and resilience-related issues for us as leaders has become paramount. But yet, it honestly, it seems sometimes that the more and more that we throw at it, our wheels continue to spin, and some of that is forcing us to take a look at a bigger picture in terms of how we're actually structuring our care, structuring our work-life balance, and it's a whole new set of challenges. So would love to come back in a year and hopefully share some newfound successes. When it comes to the patient, again, this has been talked about a lot, and I won't go through this slide in great detail, but we know that the impact of stroke on the patient, especially the long-standing complications that are unmet needs of patients, can linger and have significant downstream cost effect on the healthcare system at large, and also can take a toll on the patients' families and caregivers. So, we see significant impact on those who take care of, and not just with stroke, but we see it with dementia and other chronic disease, where the personal health of the caregiver tends to go into decline, as self-reported impacts on social life, and also their self-reported sense of strain, coupled with that the financial burdens that may also come from someone being out of work, or it can have a significant impact. And I think being attuned to all of these, what sort of struck me in contemplating this talk was this interplay that they all have on one another, and if not managed at any one point, can be sort of a recipe for rehab disaster. And we'll talk a little bit about that as well. So, we commonly think of teams, and teams come in lots of shapes and sizes, so, within your framework and construct of a team, you can feel free to type your comments in the chat, but, what is your definition of a team? I mean, a team can be, oftentimes we think of people that are part of our work group or work organization, or they're in the facility that I'm in. And team by definition is often easier said than done. And truthfully, it's even in very successful organizations, the concept of team and team-based approach is something that, again, is aspirational, but not always achieved. the one thing that is true is it is always lacking in organizations that tend to fail. One cannot be successful as an individual in a large group of people if you're expected to work with them together. So leadership and teamwork are one of those things that are two of the most common words that are placed on a resume. We know them as the important buzzwords and things to use in terms of promoting ourselves. But at the same time, it's often hard to demonstrate those. So I'll speak a little personally about that in my own lens as well. So, this idea of, what's the difference between a team and a work group? I'll speak more in the form of the reference of team because I don't need to read the slide, but I often think of a team in a sense of we, and it is, I try to look at sometimes at how many times am I saying we or I in a conversation or when trying to resolve a problem. We focus a lot on the mission of Hopkins and the mission of the Stroke Institute. We've been focusing on a short-term, and I'm going to say short-term because it's almost 5 years. We're 4 years in, but with the hope that this is a much longer relationship and allows us to continue this mission focus of not just clinical excellence in research, but also education and knowledge transfer, such as we're doing today. So we focus on a collective work output, not, what I do or, what I have done, but it's what we have done. What have we collaborated on, put together? I like to think of myself as a facilitator, and you'll hear from, and you've heard from some, and you will continue to hear from other members of the team that I'm ultimately responsible for. But, I see how their work eclipses whatever my capacity could have ever done. But I thrive on the fact that I have this opportunity, as Dr. Raghavan said, to sit at this intersection of, talent, training programs, and technology. So they're difficult to form. This has taken a long time for us to put together. We tend to be very interdependent. There's times I don't have all the answers. There's times that my teammates don't have all the answers, but collectively, when we pool our resources, we can get to an answer. So first and foremost, we start on a foundation of trust. There is healthy conflict that arises. There's debate. If we all agreed on, if we all agreed 100% of the time, I would be worried because that can lead you into problem areas. This idea of an unwavering commitment, there are times when it is difficult to pick up the ball. There are times when it is difficult to have the endurance to see something through to the end. And as we are 4 years in and hoping for this to continue, there is a sense that, through encouragement, through times like this where we take and stop and reflect, we see how far we've come and the progress that we've made. And that's not dissimilar to, why we sit down and review goals with our patients, why we use objective metrics with measuring leadership progress through employee engagement and things. So that's an important step because it welcomes accountability. When I stepped into a larger role now almost 8 years ago, I remember the first meeting I had was really talking about accountability. And it's not a comfortable thing. I don't exactly enjoy accountability because that doesn't always come with comfort. It can be a painful process and a difficult one. As we are humans, we make errors. We make misjudgments. As therapists, sometimes we take a strategy that, didn't have a desired outcome that we thought it might, or we may push somebody too hard or not enough. But at the end, when we work together and we communicate, it allows us to achieve, amazing results. And so for those that are not familiar with the 5 dysfunctions of a team, it's a great read. And it talks a lot more in depth about these concepts that I'm sharing with you today. It speaks mainly about the dysfunctions because they are the warning signs. They're the yellow light, so to speak, that should be triggering us to action, whether it be as the patient, the provider, practitioner, or the caregiver. So there has to be when there's an absence of trust, then there's fear of conflict we tend to avoid. That then can call into question the commitment that is there, and that leads to an avoidance, hiding from being accountable, pointing the finger in other directions, and that inattention to results prevents us from achieving our goal. I'll be sharing my slides with you, so I won't read through all of the detail, but there are contrasts and comparisons between teams that perform well and teams that don't. I'm very grateful to be a part of a team at Hopkins that I believe at times has got very high performing capacity. But I've also been a part of experiences where even through my own involvement or my own failure, we have not achieved the results that we wanted to. But we are very good about having a strong foundation of trust, and that trust is what helps us get through those difficult times, because it takes us back to step 1, where we're vulnerable. We acknowledge we've made a mistake, and we move forward, and we begin the rebuilding and repairing process. So this is, again, somewhat of a rhetorical question. Feel free to type any answers in the chat, or we can discuss later. But when there's a lack of trust between the practitioner, the patient, and the caregiver, we've all probably can think of an example or a time where communication has broken down. If someone came to me thinking that they were going to get the high-level care of one of our clinical specialists and all of the knowledge of a stroke, and I talk about, hey, I'm the MSK guy, there's probably going to be a quick crisis of confidence in me as their provider. We know study after study shows that patient outcomes are influenced by their trust in their practitioner and in their belief in their ability to help them achieve their goal. It's not entirely different to other aspects of our life. I had a plumbing issue at my house. I'm pretty handy and I can fix a lot of things, but my goodness, I really wanted to make sure I was confident that that guy knew what the problem was and could fix it. And when there was some question about, I may not be able to fix this, or I may not know how to, we can feel this in our everyday life, how, little slight things that we say and do can create a crisis of confidence and potentially cause a lack of trust. When there's a lack of trust, we may not share things that we would otherwise reasonably share. We need to know the full picture and understand the full story if we are to help solve a problem. The challenge that we sometimes face, both as a practitioner, as a leader, is that, to be trusted, it's been said by the philosopher George MacDonald, to be trusted is a greater compliment than to be loved. Sometimes, we want to be liked, we want to be loved, we don't want to say the wrong thing. We don't want to offend or hurt somebody's feelings. We may not want to say, I don't think you're trying hard enough. And it's hard. I've sometimes said it the right way. I've sometimes said it the wrong way. But in a trusting environment, you get feedback, and you can make and adapt to necessary change. So some simple ways to build trust is to be vulnerable, to acknowledge, your own sense um, of of weakness and confidence at the same point. But it's important to understand those perspectives and biases, as they can influence a relationship and influence an outcome. Personal interactions, I think that's one of the challenges that we face now often in Zoom, is just the access to human interaction. So, trust has always got to be moving forward. So we use, it's hard to sit down and get to know everybody, especially with a very large team. But we do that with our patients by sitting down and interviewing them, motivational interviewing. I've had caregivers and patients interview me, like they want to make sure I'm the right person for the job. But in terms of how we've implemented in leadership, as Dr. Ragavan talked about building teams, we've used a lot of different tools, things like Myers-Briggs, which most people are very familiar with. But in 2020, we implemented a really interesting tool that looks at both how we think and how we behave. So for me as a leader and looking at my leadership team, you can see like my colors without getting too deep into it. I'm a pretty conceptual, social, and analytical person, but if you want me to build a super, sophisticated, organized, structure, structurally, that's not my strong suit. So, what's important for me has been to build a team around me that has strengths that can help fill in my gaps. And I think that has really helped us tremendously when it comes to getting to where we are today with the Stroke Institute and our teams that are involved, and you'll hear from them a little bit later. So balance is critical. Know yourself. The West Point leadership model talks about know yourself, lead yourself, and then lead others. I've spent a lot of time learning about myself, and I have a good sense of where I need help. Something that we're piloting in 2023, and I'm really excited to get this off the ground, and we'll look to see more from this in the coming year, because it's from an affordability standpoint, a scalability standpoint, it's a lot more comprehensive, as it looks at different thinking types and how our roles and responsibilities fit within the architecture of a team, looking at things like our energy rhythm and even times when we should be getting together to solve different problems. We all have different rhythms in our day, and if my entire team is afternoon people and I'm a morning person, I've got to find a way to get in sync with them, and vice versa. So I'm excited about this, as we've just started to roll out the pilot this spring. When we appreciate these differences, and when we start to see how we perform in these different types of tools, it can lead to conflict. There can be disagreement. When we have conflict without trust, it's an argument. There's no safe place for arguing in the clinic or in the exam room or anywhere else for that matter. But when we have conflict with trust, that's a debate, it's a discussion, it's something that we can work towards for resolution. But if we don't have a foundation of trust, it's hard to have those types of discussions. So we have to start there first. Sorry for the gender reference here, but this is an older quote, but all men have an instinct for conflict, and at least all healthy ones. And I'd say that to all of us. We particularly those that are much more scientifically inclined, they're truth seeking. So just accepting a simple answer is in their way. Science is a way of trying to resolve that conflict of ambiguity and precision. So, there's a lot of different ways that we can master conflict. The one that I commonly go to is I was wrong. I reflect and try to look at, where did I contribute to this conflict and how can I help make it better? When we seek to first understand and then to be understood, a very simple basis for safe conflict resolution and conversation can occur. Positive conflict usually involves a level of passion. And for people like myself who tend to be more expressive, I'm very passionate about what I do. I wouldn't put energy into it if it didn't mean something to me. And if I didn't perceive that it offered value to the people that I'm responsible, both to lead as well as to care for. Our goals are always to have equitable outcome. And that leads us to commitment to a cause. How do we, get buy-in? And that comes through clarity, and that's a challenge for me. I'm conceptual. I'm not structural, right? So, trying to think through how do we frame our goals, our steps to a process has been important. And I think that's one of the key takeaways from all the work that's been done with SKSI is working to create pathways, predictions and expectations so that we all know where we're moving on a path. When we think about the differences between contribution and commitment, I'm making a contribution to today, but a full commitment is what the chicken gives the eggs, but the pig is committed to that process. So, we have to frame things as well in, where are we trying to contribute to our patients' clinical outcomes. When we have buy-in, when we have precision, our goal with commitment is really to defy the idea that there is any lack of consensus. We want to have agreement that a patient's stated goals and outcomes are within the realm and possibility of what we can offer based on our current understanding of medicine and rehabilitation. Achieving that commitment, to do that, people need to be heard. So listening to your patient, listening to their caregivers, allowing them to be heard is important. And sometimes, we have to acknowledge the role that, sometimes our job is to listen, as opposed to dictate or to tell. So there's a number of different strategies that we employ, whether it's, trying to keep our work, our teams and groups small. We add diversity, as I evidenced in our emergenetics. The one that's always a challenge for me, and I know that some people on my team will be smiling, having that devil's advocate, the person who is the planned or strategic dissenter. They can help by testing what our thoughts and goals are. But by providing places for people to speak up and share their mind, it helps to uncover or elucidate, attitudes or concerns. And don't overly rely on experts. Sometimes we find ourselves in that spot. I won't go into my personal examples with patients, but there's times when patients have taught me some lessons about their therapy and what they can and can't do, or the way that they could make an exercise work at home. So, the more that we share collectively, the outcome is that much greater. In the Stroke Institute, the team has done an amazing job of putting together a a packet of information, of education for our patients to follow. And for that, it allows us to embrace that accountability, making sure that we're meeting their goals. By modeling it, we're seeking first to understand and then to be understood. We want to, ask people what they would like or what do they think about this. Sometimes I may present a goal or an expectation, but I'll put it back to the patient or put it back to the caregiver to see if this is something that is achievable. So as we do this, it will help us achieve better results. We have to question ourselves internally and reinforce this acceptance of responsibility. Meetings are designed to help place accountabilities. I'm almost finished. There was an interesting study that was done on other-centeredness. And, Byerly talked about a study where 5 $2 bills were given to a group of people, and they looked at how people would distribute those funds. They couldn't keep it all. They had to give some of it away. 32% promoted others over themselves in determining what they kept and what they gave away. So we have a strong natural tendency to look out for others, I think as healthcare providers, oftentimes greater than ourselves. Setting up dashboards, setting up metrics, this is something that, again, using different tools, whether it's our clinical dashboards for outcomes or operational dashboards, and even how we survey our own employees looking internally for how they're doing with resilience and satisfaction. Getting results, especially as a team, is the most satisfying outcome because it was done collectively. There's a proverb that says, if you want to go far, go alone. If you want to go fast, go alone. If you want to go far, go with a friend. And that is, something that is central to my theme. Almost done. Being well promotes well-being. And so from a leadership standpoint, from a practitioner standpoint, both having been a patient as well as a provider, caregiver, it's important to know where you fit on that continuum and to encourage trust and communication. Promote vulnerability within your relationships, discuss your differences, be consistent with your effort, encourage one another along the way, measure your progress, and always celebrate success. We know that if it was easy, everybody would do it. And that's why we're all here. We're putting a lot of effort and a lot of work into doing something great. So with that, I want to say a very personal thank you to the Sheikh Khalifa Stroke Institute and for all of the people at Johns Hopkins Hospital who participated in the care of my sister who had a stroke last June. Dr. Bahuth, Dr. Krasna, Dr. Raghavan, and a host of therapists and people who provided care on the floor as well as an outpatient. My family thanks you, and I think a lot of others do as well. So thank you. Keep doing great work, and I appreciate the opportunity to be here today.